Dr. Rayyan, thank you so much for meeting me today. Since I've seen one of your talks a number of months ago, I have loved the amount of knowledge that you have in relation to psilocybin, and particularly knowledge to do with psilocybin for overcoming addictions, because that's what you did your PhD on. You did that at Imperial, you're now post-PhD, and you're a fellow at Imperial doing more research. I guess the first thing I want to ask you is, what is the most helpful thing for our audience to know about why you're here and what brings you kind of to be doing this interview with me today?
Yeah, well, yeah, thank you for having me. And I guess a lot of my sort of curiosity about this whole field, like the wider ecosystem, started from my kind of curiosity about the brain and the mind. So really trying to understand, are they the two sides of the same coin? Are they two separate entities? And it goes back a lot to like Descartes' idea about the brain-mind dualism, or Cartesian dualism. Yeah, so basically looking at the brain and the mind has always been something that kind of piqued my curiosity. Like when I was like earlier on in my childhood, I had like family members who had some mental health problems, and I was always interested in why that was the case, why some people, you know, seem to have this malfunctioning of the mind and like how that translated to their bodies. And I really wanted to see whether there was a link there. And so I went to university, I did biomedical science, and I wanted to really get into the mechanism of like why things were happening in the body. But, you know, I was never really interested in like other organs like the heart or the kidneys. Like the heart is a pump and the kidneys like a filter, but like the brain is this like supercomputer which kind of governs the entire reality in which we live. And so I thought, wow, like what, isn't that the most fascinating organ to study, to really understand humans and humanity and disease? So that was like kind of my general interest in the mind and the brain. And then sort of as I was going through my academic development, David Nutt and Robin Carhart at the Imperial Center for Psychedelic Research, they had just published some really pioneering research, the first brain imaging study in LSD. And growing up in like the north of England, there was a lot of drugs around me as I was growing up, a lot of party drugs. And I just found it very curious that like people were having different experiences with these kind of recreational drugs like MDMA and psychedelics versus alcohol and like, you know, some of the recreational illegal drugs, and just the way that those kind of drugs made people feel. I was very interested in like, even before this research had become clinically available, I just thought, I had an intuition that like, I mean, MDMA makes you feel great. It makes you feel amazing. Like, surely there might be something that's, you know, kind of deeper to that, which could be kind of deployed therapeutically. So that was a very kind of nascent sort of understanding of like the value of drugs clinically. Then, you know, psychedelics and people that have tried that, they also report this kind of connection. And so when that research came out, I just kind of angled my career towards trying as much as possible to kind of work with them. And so I was lucky enough to get a government fellowship. I think it's actually the only one that the Medical Research Council have given out for a PhD in this area. So I was very lucky to get that. And then, yeah, I've been there for the last 4 years, as you said, like studying the clinical effects of psychedelics and the brain mechanisms behind it in people with addiction.
So that's really good insight. I want to delve into your background just a little bit more, Rayyan. So you kind of saw something about the mind-body connection. I'm just wondering, was there any experiences where you felt, wow, we are really disconnected, or there's something like happening in this world where actually we need to do things differently, or we need to like figure out how to solve the problem of like people struggling so much or being so disconnected, like mind and body wise?
Yeah, I mean, I guess the key thing that made me realize that we needed to solve the mind-body gap was based on the inefficacy of psychiatric drugs, because psychiatric drugs work on a very biological target in the brain, but with very limited clinical efficacy. You know, a lot of people relapse. In fact, about 60% of people relapse to addiction-related drugs within a year, you know, around, the same amount for antidepressants. And that shows us two things. It shows us that our understanding of the biology that might be serving disease of the mind and psychiatry is not quite there. But it also shows us that maybe we are disconnected in our own ways of scientifically and medically thinking about the body. It's not just biology, it's maybe this wider thing that we now call like the biopsychosocial model of disease. And I think what psychedelics do and what we show them to do is that they're not just biological agents like SSRIs or other drugs. They have this psychosocial kind of element. Although that's triggered biologically, it causes this shift in spirituality and connection with the self and connection with the environment you're in and each other. And so for me, that's fascinating because that's holistic medicine as well as being a biological medicine. And I don't think in the history of psychiatric drug development, we've ever had anything like that. So that's why I think these are almost like the ideal candidate to explore for that use.
Yeah, very well explained. And it's so exciting because I'm very passionate about helping get people off psychiatric medication. That's one of the things I'm just, really into, particularly from personal experiences of people I've known who have where psychiatric medication has just not served them well, and they become dependent on it for very long periods of time, for a lot of people, their whole life, and then it's very hard to get them off it. So what you're describing is like, so exciting because it's like, oh, wow, there might be something out there that's just different to people becoming very dependent on psychiatric medication.
Yeah, no, definitely. And yeah, I guess one thing I do want to say, and I don't know whether you feel this clinically though, is that whilst I support psychedelics, antidepressants still do work for a lot of people. And from some of the psychiatrists, even Dave Nutt and some of my other colleagues, they really are it's quite important to state that like they might not cure everything, but for some people, in very severe states of depression, they're clinically useful tools and they may prevent an individual from doing something harmful to themselves. So yeah, whilst, it's not perfect, I think, as like a first line treatment, CBT, SSRIs, it's a good idea if you are in a chronic place, if it suits you. But like there's people in the psychedelic community that really disagree with that and think that, they should all be outlawed. But the data does speak for itself that there are a significant majority of the population that do respond, but there are still people that don't. But it's, I think it's about balance and about nuance, and not all psychedelics will be appropriate for everyone because not everyone wants to take them. But we do need to rethink the way that we address mental health treatments, I think, and that's what psychedelics can offer.
Absolutely. That's really well said. Yeah, because we're definitely not saying no one should take antidepressants. They do save some people's lives. I think the problem is that they are often prescribed too quickly and for issues that are far more mild than really needs them. And then that prevents people from developing the coping strategies that they otherwise would be able to develop.
Yeah, no, I agree.
I'm curious about your findings. So you really delved into how psilocybin-assisted therapy could help people overcome addictions. And you spent, how many years did you spend researching this doing your PhD?
So it's been about 4 years. And now we're really kind of starting some more mechanistic work. So we've been developing, I can't claim the credit for this. Actually, it was the founder of the AA, Bill Wilson. In 1934, he went to a New York State hospital take this mixture of different delirium. So they weren't psychedelics. It was drugs like henbane, belladonna, but they cause these kind of profound changes in consciousness. I think it was his fourth attempt to quit alcohol. But under this experience, he saw this kind of bright white light. Then he had this transcendent experience. And it was in that moment that he realized he could actually maybe live a life without alcohol. He kind of disrupted the thought processes that were kind of driving his cravings. And he felt free for the first time from kind of the shackles of his own ruminative, addictive thinking processes. He then convinced the NIH, which is the kind of major public health science funder in the US, to fund 6 trials with 500 patients given 1 high dose of LSD. Now, in those studies, there was a meta-analysis done where we looked at kind of the culmination of the studies, and individuals given LSD were 2 times more likely to stop drinking alcohol and to reduce their alcohol intake than the placebo group after just 1 high dose, so 1 12-hour session of LSD. Now, when you compare that kind of effect size to current medications for alcohol use disorder, so there's something called nalmethine, acomprozate, disulfiram, you may know some of these yourself. And, that's about LSD performs about 2 to 3 times better clinically than currently licensed drugs based on that old data. So we already kind of had a hunch from this historical data that, in randomized controlled trials, it seemed to work. Now, after 1971, when the Misuse of Drugs Act was brought in, there was basically a ban. Like, most psychedelic research stopped for over 40 years. And then our group at Imperial was actually the first research group in the world to really resurrect that, which is pretty pioneering work from Robin and David, and courageous, given 10 years ago this was super taboo, and it's only recently that things are changing. But I guess when I came on board, they really just looked at depression prior to that. But I kind of came with an idea that another big area to kind of focus on is addiction, and that's some work that David Arizzo and David Nutt, two of my supervisors, are also massively into. So what we've done is we do something called neuropsychopharmacology, which is basically, we're not just interested in like how drugs work, whether or not somebody tells you they feel better, or the clinician says this person's improved. We want to really go into the brain, and that's kind of where my fascination about this group and the research, I think, has a lot of potential, is because we can image the brain in several ways, start developing an understanding of how molecules like dopamine and serotonin link to brain function, so your reward processing, that's very key in addiction, and then how that leads to clinical outcomes, so whether or not you're addicted or whether you're not, you're free from addiction. And so we're looking at specific pathways in the brain. It's called the reward pathway, or the mesocortical limbic system. And we've developed these tools that can start to assess how psychedelics can change the way that pathway works. Because what we do know in the last 20, 30 years of research into addiction in the brain is that this pathway seems to be dysfunctional. So the key question that we're trying to answer is, does psilocybin or other psychedelics restore the dysfunctional reward circuitry in the brain? And if so, is that what's causing the recovery? Because what we know is people recover. We know that people take psychedelics, and generally speaking, the vast majority do well. But we have a bit of a black box of knowledge. And that mechanistic understanding the mechanics of how it works, will help us to optimize therapy, will help us to identify new targets in the brain, to make what we call second and third generation psychedelics. Like, we're thinking about, there are going to be patients that maybe don't respond. Why is it they're not responding? Is it because we're not targeting the right structures, the right systems to kind of give the kind of full psychedelic experience? We don't really know that question. So I actually don't have an answer about why. Yeah, it works. But I guess in like the next 2 years, actually starting early next year, we'll be putting the first patients with like gambling addiction and heroin addiction in a scanner after taking psychedelics, start understanding the brain mechanisms. So we're super, super excited.
That is really exciting that you're now moving on to other addictions, so that you can start to see actually the impact there. So just going back to the reward circuit in the brain, what did you find so far on the brain scans?
Yeah, so we wanted to look outside of classic addiction to gambling addiction. So gambling addiction is like only in the last 7-8 years been recognized as a mental disorder. So it's diagnosable by psychiatrists. But the fascinating thing, the reason why we wanted to do gambling addiction is because there aren't any licensed drugs for it. There's also limited understanding of what it is in terms of how it develops, because it's a behavioral addiction, and behavioral addictions don't need a substance. It's a repetitive behavior that leads an individual to develop these problems. But clinically, what we see is that a lot of patients have similar characteristics. They have craving, they have withdrawal, they have negative mood. We want to scan their brains and essentially compare it to individuals with addiction. And what I found were a few things. Basically, the same reward pathways in behavioral addictions are dysfunctional in people with substance use addictions like alcohol or heroin or cocaine. It's that same reward pathway. And although there's some slight variation, dopamine doesn't seem to be as much of like a crucial mediator, but there's some other systems like the endorphin system seems to be involved. And there's also some dysregulation in the serotonin system as well. But yeah, so what we found was basically that the brains of individuals with gambling addiction seem to concentrate in a scanner, when we show them gambling videos, very, very highly on that, and to natural rewards like social rewards, food, nature, their brains really have a hypoactivity. So their reward system is imbalanced. And so, yeah, we basically characterize one of the first studies that gambling addiction has a neural correlate to it, which is not something that has been readily explored. But the other reason why gambling addictions I find super interesting is because it's a substance-free view of addiction. So drugs can have a neurotoxic effect on the brain, and that might then catalyze changes in the way the brain functions. Whereas with gambling addiction, as a scientist, you're given almost, I wouldn't say luxury, but you're given the ability to actually image the mechanics of it without a confound like substance use. So it's really getting to the core of how the behavioral processes are hardwired in terms of neuroplastic effects in the brain. They're kind of like the main findings that we are like beginning to publish. And we've also basically developed a probe which can like really look at the mechanics of addiction in a very, very nuanced way, looking at these molecules. They're looking at dopamine, endorphin, serotonin function, and how that relates to how a brain responds to rewards. So it's quite advanced neuroimaging. I think there's only about 3 scanners in the world that can do that. And so we'll probably have the strongest insight in terms of how psychedelics and disrupt that system as we publish our findings over the next year or so.
That's amazing. Are you noticing huge belief changes in people with gambling addiction? Because the unrealistic beliefs, from my experience, kick in when they're in that mode of they've been triggered and they're about to start gambling. That's when I can win it all back, and all these unrealistic beliefs that are actually fueling the behavior. Have you seen anything in relation to belief change yet?
So actually, we haven't actually dosed a participant in the gambling study. So the study I mentioned was just a neuroimaging one. So we needed to validate some kind of tools in the brain before we use it, and that took a long time to really figure out. We'll be dosing our first patient in February. So nobody in the world has yet currently received psilocybin in a clinical trial with gambling addiction. So we'll be the first group to do that. But when we look at other kinds of groups that we've given it to, so people with alcohol addiction, the core process that they found was self-efficacy. So that's a key mediator of success. People were just able, after taking psilocybin, to believe in themselves that they could recover. They believed they could handle emotionally, psychologically, behaviorally, any substance-related urges, and they could just believe in themselves to say no or to stop their behaviors. So impulsivity and compulsivity are big drivers in addiction. It's kind of this automatic behavioral reflex arc that happens after a while. You get so conditioned that actually many addicts think that they're almost automatically taking drugs or using substances even offline, even if they don't want to. And so they say that they're able to kind of stop that reflex. But also attitudes in general to like the worlds in which they live are quite drastically changed. They kind of start, they feel very disconnected. When you're constantly in your reward system, you generally tend to block out the world around you. And that's what we've seen with these neuroimaging studies. You don't respond to nature, you don't respond to family, you don't respond to like social situations, you don't respond to even things like sex or food. Like all of these kind of basic primary rewards are put second. And so for years, individuals almost feel lonely and isolated. The only source of pleasure, well, it's not even pleasure towards the end of addiction, but the only thing driving them is their addiction. What they find for the first time after time in therapy usually is this reconnection to all of those primary rewards. I think that's where a lot of psychiatric medicine kind of fails more generally, is that whilst they may decrease the symptom, they don't increase the functioning of an individual. And that's separate scales. Well-being is super critical, I think, to generally recovering from any psychopathology. And interestingly, in one of our studies with depression, what we found was that we saw decreases in depression scores, but we saw massive increases in well-being. And we think this twofold mechanism is what is very special about psilocybin and what differentiates it from other like pharmacological treatments for mental health disorders.
That's really well explained. It's so powerful that with this, people can actually reconnect with their loved ones. They're more interested in socializing. They're more connected to themselves and more connected to nature. It's like they start living life again and finding meaning in life.
Definitely. It's really is fascinating. And the reason why that happens, I guess we don't know. And that's sort of why groups like ours we're really trying to pick that out, because that can really tell us about the core of disease as well. So if we find out what changes in the brain to make an individual better, then we know that it's that specific mechanism which is causing the destruction or the dysfunction. And so we can start targeting the kind of key disorder specific brain circuitry that underlie disorders. So it really is like it's great to know that drugs work, I guess, because then we can know what makes people ill at the same time.
That leads me to, I guess, ask you about the insight that you've picked up on in relation to what makes people ill. I know that when I was working a lot with alcohol, about drug and alcohol when I was doing my doctorate. That was like all on my placement for 3 years. And it was very interesting actually, because people who had problems with drugs were very different to people who had problems with alcohol. And what I was seeing, sadly, with people with alcohol was just so much trauma, particularly sexual abuse. I couldn't believe like how much I was hearing that with, you know, almost every client who would come and sit with me. It was like another story of being sexually abused. So I became very aware that trauma, particularly trauma of that nature, was definitely something that, you know, fuels alcohol addiction for a lot of people. I'm kind of curious about what were you picking up on in relation to some of the causes from the work that you've been doing?
Yeah, I mean, yeah, trauma is definitely a real big driver of addiction. Gabor Mate is a very famous psychiatrist, neuroscientist, says the question is not why the addiction, it's why the pain. And I think that's a really powerful kind of testimony, asking individuals with addiction, not why they got addicted to something, but like what is causing your pain, will you get to the bottom of why they are using substances to cope. And alcohol makes sense. Like, alcohol masks the brain's ability to cognitively process things. It shuts down the frontal cortex, which is the thinking brain. And, you know, if you're stuck in your thoughts the entire time, recollecting traumatic memories, trying to process what's happened to you if you've been abused, then alcohol is the perfect drug for that, because it just kind of, you know, dampens down your brain. So I understand completely why people would turn to alcohol. There's no blame in it. It's sort of, you know, a thing that's very readily available in society for people to cope. And that's what a lot of people do. People self-medicate maybe into addiction from traumatic events. There's other types though. So there's the kind of trauma-informed addiction kind of psychopathology, but there's also, you know, iatrogenic addiction. So by that, I mean like individuals that take drugs and without the intention of getting addicted, and, you know, end up dying. And that the perfect prime example of that is the opioid pandemic in the US, which, you know, killed hundreds of thousands of individuals, caused severe destruction. And that was started by pharmaceutical companies, Purdue Pharma, basically prescribing very strong opiate medication, oxycodone and OxyContin, to individuals who had pain. And although it treated the pain, they developed these severe addiction, like physical addictions and psychological addictions. And that's what we call iatrogenic addiction. So that was never, you know, these people might have been doing perfectly well in life. A lot of them were. They had, you know, functioning jobs. They may have had a car accident. In fact, Matthew Perry from Friends, who recently sadly passed away, his journey with addiction started after a jet ski accident, and he was prescribed Vicodin, which is an opiate painkiller to help with that injury when he was 17. And then he got up to taking 55 pills of that a day, he said, which is an absurd amount. But, you know, unfortunately, he's passed away and he's had a lifetime of issues related to drugs. So it's really, it can be twofold. It can be trauma related, or it can be kind of de novo. And there's kind of like a third group as well, I think. And they're less like accounted for. I think there is a level of biological heritability that's definitely something we see. So individuals with first degree family members who have addiction generally tend to inherit those genes. And when we do brain scans on them, we see that the way that their brains process reward, we call them ultra high risk individuals, where the brain process of reward is kind of similar to that of an addict, even though they're healthy at baseline. So we can even see kind of these reward deficiencies or differences in the way their brain processes salience or important things in the environment.
Is that a genetic thing, or is that a learned behavior because they're being raised by someone who's emotionally quite stunted, so therefore they're not getting the nurture that would benefit them the most?
So one way that they actually kind of tease apart it is by doing twin studies. So really fascinating study was done where they looked at twins, one who had an addiction and the other that didn't, and they compared their brain pathways, and usually that parent would also be an addict too. And so environment, because they're brought up in the same environment, that's kind of controlled for naturally. But when you compare the twins' brains, you can see that the individual that's not addicted still has some kind of discrepancies in their reward system circuitry. And so what that tells us is that there is a biological element which might be more nature rather than nurture.
But they've been raised by a parent who has an addiction.
Yeah. So there is an element to it, but with addiction, it's both. It's epigenetic, so that's the way that the environment kind of shapes your genes and your DNA and how you express these kind of risk genes that may confer increased risk to an addiction, as well as some kind of heritable biological trait. But I guess the real answer is it's a mix. It's the biology, it's the psychology, it's the social environment that collectively basically determines your risk of developing an addiction. And so it's not one in its own right, it's all of them.
When you can scan an individual's brain and you can give them feedback on how much of a risk they are.
So we can become at a population level. So when we do, maybe 30, 40 patients in a scanner, we can basically say that this group has a higher risk than this group because they have these sets of characteristics. To some degree, we're now getting better at doing prognostic brain imaging, which is in the level of N=1. And so that basically, the purpose of it, and a lot of the work I'm involved in, is actually kind of make those kits or those technologies more readily available for clinicians. And I think in the next 5 years, we'll get there, such to the point where, as a doctor, you'll be able to have a patient come in, maybe scan their brain and do some other tests, and you might be able to give them kind of an individual kind of risk profile. And then also based on that, stratify them to specific drugs or treatments so that they can be better matched based on the brain phenotype and what they present. And so, that kind of precision medicine and personalized medicine approach is coming to psychiatry and psychedelics. And so we're getting there slowly. And I think in our lifetime, we'll 100% see that.
Wow, it's really exciting because it kind of, I guess, leans into more functional medicine and functional health rather than waiting until we're unwell before we get treatment.
Yeah.
So I want to go back to your research. How many participants did you have for your research?
So I did like 3 different studies for my PhD. So I had 20 individuals with a gambling addiction. I had 20 individuals with an alcohol addiction. And then I looked at some other research which covered actually like 2,000 patients with addiction, which are kind of big data banks. So what we do is what we call very early stage, mechanistically informed research. And the value of that is it allows individuals to allows scientists to basically start figuring out the kind of basic targets for how we can improve novel therapeutics for patients that have addiction. Then the usual thing that happens after that is with that early evidence, we speak to biotech companies or psychedelic companies that want to develop their compounds. And we say that, hey, I think maybe based on our findings, your drug might be a good match. So let's now trial it in a larger trial. So we do like kind of phase 1, phase 2 trials, which are very early stage medicine development. And then later down the line, kind of big pharma, phase 3 and thousands of patients. But it's really this grassroots kind of academically informed university research, which I think is a cornerstone of most of the medical advancements that we see in society. I mean, it all starts from kind of fringe experimental medicine groups. And I guess our group, the way that we found ourselves was based on, some of the really exciting findings we had over 10 years ago. Which has now catalyzed the wider psychedelic industry that is pretty much booming now. It's worth about 8 billion. It's going to go up to 16 billion. There's a lot of venture capital, media attention, biotechs, clinics, retreats, training programs, governments talking about it. And that all really stemmed from the first finding of Imperial in 2016 that we published, which showed that out of a group of 20 patients given 1 dose of psilocybin, 70% recovered within a week, and they stayed well for 3 months. Like that catalyzed this whole space. And so even though it might not sound crazy having 20 patients or, in a group. Like if we find something with a big enough effects, the kind of way that can develop and create a whole new sector in science is, well, it's been proven to be, kind of beyond what we ever thought. So I find it really exciting. I love this kind of early, figuring it out, developing questions and ideas. It's definitely exciting to kind of put heads together and think, how can we solve our next question? And the other thing is to say that we never really are satisfied with answers. And I think that's kind of the bane of most scientists, is when we find something new, we're like, oh, then why? And then we come up with 10 more questions. So
yeah, amazing. So I'm curious to hear about your opinion on the psychotherapy side of things, because my understanding is that right now they don't dictate what type of psychotherapy they're including. Psilocybin-assisted therapy. It's just to have the psychotherapy element. What are your thoughts on this?
Yeah, so I mean, psychotherapy is really important. It's critical, I think, to the patient journey, although not everyone believes that. Some people believe that. So there's two phrases: there's psychedelic therapy and psychedelic assisted psychotherapy. The term that I think is now being used more is psychedelic therapy rather than assisted psychotherapy, because the assisted psychotherapy implies that the psychotherapy is the main component and it's a psychedelic which supports it. But on the contrary to that argument, without the psychedelic, you can never really catalyze the same level of clinical effect. So it's actually the psychedelic maybe doing the main work and the psychotherapy supporting that kind of structure around this brain change. And I think I sit more in that camp, because we do know that psychotherapy is by and large ineffective for a lot of people. Just generally talking, has not been proven in lots of studies to be effective for us. So with the psychedelic angle being kind of the main catalyst, psychotherapy is important. So that's about that. What we haven't got an understanding of yet is what the best form of psychotherapy is. So what we use is something called acceptance and commitment therapy, which is based off a model that a lead psychologist of our first trial, Dr. Rosalind Watts, and it's based off 4 principles called the ACER principle, which stands for accept, connect, embody, and respond. And it's just really about kind of surrendering to the experience, letting the medicine sort of bring up whatever needs to come up, and processing that. So it's kind of just a deference to the medicine. There's other types of therapy now that are now being explored slowly. CBT therapy, which is more cognitive, psychodynamic therapy, which is more into kind of the psychedelic sort of thinking. We don't know. And the reason why we don't know why psychotherapy works is because, unfortunately, it's not profitable for businesses. It's not profitable for pharma companies to really explore that question, because you can't really put a package on it. And I think actually a more pragmatic view of it is that I believe that each individual probably needs a tailored psychotherapy, because I think we're all very different. And I think if we start labeling psychotherapy practices specifically to psychedelics, that can restrict the clinical deployment. Some people are more responsive to psychedelic, others to CBT, and that's just based on really you and your kind of core pathology. And so we definitely need more studies to figure out who is best sort of served with what therapy. But right now, because it's more in a kind of medical zone and medical development, the focus is really on just having psychological support. That's the name that we give it, with prep and integration. And it's kind of a loose term. And I think it's purposefully used so that when doctors can prescribe it in the future, they're not restricted by the FDA label. So therefore, they won't be able to get reinsured from public health systems. So there is a sensibility to it. It's not just people have just forgotten about it, sort of thing.
Is there certain guidelines for the therapists that are involved in the research that you're doing so that they know how to handle certain things? So for example, if someone has some very interesting cognitions, very interesting thoughts or images go through their mind when they're going through the therapy, and then they just don't know what to make of it, and then they truly believe one thing and they say it out loud. A therapist could either validate that and kind of say things that then feed into that belief system, or they could challenge it, or they could shove too much of their own beliefs onto it. So this could be quite challenging for a therapist to know what to do with certain information that the person is presenting with, because people can be quite vulnerable after psychedelics. They're trying to make sense of all this interesting stuff that has come up, and they're perhaps relying heavily on the therapist to guide them and help them make sense out of what otherwise might be a bit of a confusing state that they're in. So I'm curious about the guidelines that you give therapists in relation to dealing with that kind of thing.
Yeah, so I guess a lot of our therapists are, they are all trained psychiatrists or clinical psychologists or guides, and there's always one kind of clinically trained professional in the room. So they already have an idea of psychotherapy and psychology, and from their own training, either doing medicine or doing a doctorate in clinical psychology. So that kind of safeguards the kind of basic practices about how to deal with individuals who are going through any kind of psychopathology. But then on top of that, they have specialized training. So we work with a group called the Institute of Psychedelic Therapy in the UK. So the IPT, and they're amazing. They, been trained by some of the founders of kind of psychedelic therapy, Bill Richards in the US and some others. And they've got a program. And actually, if you're interested in training, you can actually go to their website and look at some courses that they offer. And they really go into the depths of the education that's needed and training. And we would never put anyone in a room with a patient that's vulnerable under that kind of life, very, very profound life experience if they weren't ready for what comes up, because sometimes it can be very overwhelming for the patient, and therapists need to really be prepared to navigate some very complex sort of states that individuals can get into during a trip, reenactment of trauma, hallucinations, that very severe mood fluctuations, emotional catharsis, all these things happen. It's not like normal talking therapy, and so there is definitely an element of training that's required. So yeah, we do train all the therapists, and in the future that will probably be the kind of basis on which psychedelic therapists are allowed to practice legally as well.
That's really informative. And so in relation to counterindications, what patients are you not permitting into these studies because they have a particular diagnosis already?
Yeah, so unfortunately right now we don't give it to patients who've got schizophrenia or bipolar or a history of manic disorders. And that's because there's concern that psychedelics by their very own action, they cause an increase in what we call brain energy, mind to expand slightly and take on board new information and restructure thinking processes. Patients with schizophrenia and bipolar and mania, we call these externalizing mental disorders, and they're essentially characterized by having brain and neural pathways that are kind of projected outwards. Whereas in disorders like depression and addiction, they're characterized more by these kind of inward, internalizing disorders, rumination and thought cycles. And so, at a very kind of mechanistic sort of sense, psychedelics work on all of those kinds of clusters of internalizing disorders because they kind of break apart the brain that's already very rigid. Whereas in schizophrenia, the brain is not so rigid. It's a little bit more kind of complex and loose. And so by putting an agent which already kind of further expands that, the worry is that you can trigger de novo or, even make symptoms worse. So that's a kind of clinical concern. Although recently a study was done by Compass Pathways in patients with bipolar type 1 disorder. So that's not the most fluctuating moods, it's like kind of more depression based, and they found that patients, small group of them, 15, I think 12 of them had a clinically significant response to the psychedelic therapy. So I think slowly as we become more sure and aware of the boundaries of these treatments and how to make sure they're safe, that maybe there might be a space, but for now I think we're still quite early stage. So I think patients with schizophrenia and so on, probably this treatment won't be delivered to them yet.
What's the time frame in the UK of legalizing treatment with psilocybin?
Yeah, so I always get asked this, and every year I add on a year.
Oh no! And this is, it's so revolutionary and clearly has the ability to help so many people.
Yeah, the key thing in the UK is finishing these phase 3 studies. So Compass Pathways have just started this week dosing patients in their phase 3 clinical trial for psilocybin therapy for treatment-resistant depression. So that's been a long time coming, because we did the first trial for them with their drug 7 years ago. So it's taken 7 years to get to phase 3, and it will probably take another 3 years for them to finish that kind of study. So I think 500-600 patients they need to dose in multi-site centers all over the world. and then collect the data and submit to the FDA. So maybe 2027 in the UK for psilocybin, or 2026 at push. MDMA maybe next year. So MDMA for PTSD, they've just finished their phase 3 study this year in the US, and now the US and the UK have this kind of joint regulatory system such that drugs approved in the US can now maybe be approved here too. If that goes ahead, end of 2024, so maybe this time next year, MDMA could be a licensed therapy for patients in the UK. So that will represent the first kind of psychedelic like treatment available on the NHS.
Very interesting. So things are starting to change.
Yeah, it's really happening.
Yeah, it is really happening. Is there anything else that's really important for you to put across to the public at this point about your insights, your knowledge, what you've noticed about things since being involved in this area of work?
Yeah, I think it's important now to kind of proceed with caution and pragmatism and evidence rather than hype or hope. There has been, quite rightfully so, there's kind of surge in interest in psychedelics. There's been a lot of promising results. And the reason I say promising is because I think that's all they are right now. I think until we do these larger phase 3 studies, which by the way, I think will work, but until that's proven and written down in evidence, I think it's unscientific and unmedical to kind of claim them to be, cures or silver bullets. Because I think the whole kind of purpose of this movement of drug science in general was to kind of be driven by evidence. And evidence has a very concrete way of being delivered, and certain statistics need to apply to it. So pragmatism, wait for the studies to say what they say, a culmination of studies, and then we can start having a medical debate about its utility. And I think they're amazing treatments for what we've seen so far. But I think we do have some work to go before we can be sure that they're going to be completely, safe, tolerable and feasible to use more widespread. So one thing is be grounded in science and be grounded in evidence. And anecdote is great, but the media love anecdote. The media love to kind of show stories on the extremities. And that's what I've also seen is, you'll either hear, 10 years ago, you're going to like fall out of a window and, kill someone if you do psychedelics. Whereas now psychedelics are going to cure the world. Like it's just polarized because that's clickbait. In between those two extremities is kind of where the science sits. And psychedelics work for some people, but they also don't work for other people. And they're not silver bullets. And there's a lot of work that comes with it. It's not just take some mushrooms in a room and the next day, you're happy as Larry. It requires so much more process and work. I think the other key thing I want to kind of get across is that, it's great and it works, but there's a lot more to it, a lot more personal work that's needed. And it's a continuation of psychedelics give you the tools to kind of navigate life. It doesn't give you an easy life because life throws all the lemons. It's just how you deal with them. So, yeah.
I think that's really good advice. So you're telling people don't necessarily run off to whatever shaman you can find in Peru just because it's not accessible here yet. And don't assume it's going to just be the quick fix, because I think that's sometimes the problem with psychiatric medication. People go on it very quickly because they want to fix everything for them. And are you aware of any of the differences between ketamine, MDMA treatment, and then psilocybin? Do you know who's faring best in all of this, or you can't necessarily compare?
Yeah, I mean, we've not done any head-to-head trials looking at ketamine versus psilocybin. But what we do know is that ketamine generally needs a lot more therapies, like sometimes up to 8 different dosing sessions over 2 to 3 month period, and the effects sometimes for some patients seem to wane at 6 months. Psilocybin therapy is kind of a one-off, and you have months in some people, up to 6 months, even some people for a lifetime. So the dosing of psilocybin is less. The reason why, maybe it kind of opens the neuroplastic windows in the brain a lot better. We're now trying to figure out that the length of the pharmacological effects of the drugs generally tends to tie in with how much neuroplasticity changes, and ensuring in that process that you can do the work. And so psilocybin lasts for 6 hours, so a larger therapeutic window for change than ketamine, which is about an hour. But so we're seeing these kind of more enduring of classic serotonergic psychedelics, DMT, LSD, 5-MeO-DMT, and psilocybin. The glutamatergic psychedelics or dissociatives like ketamine still effective. MDMA seems to actually be doing relatively well, but I mean, it's going to be different for different patients. But I see the future of this not being just an individual giving one drug. I can imagine a future where they get all of it, maybe MDMA, maybe psilocybin, maybe a bit of ketamine. I mean, I know that sounds pretty ludicrous. It's like throwing all in, but there's a rationale because they all kind of do a bit of a different thing, and maybe different kinds of people need different things at different points in their recovery journey. So yeah, I think that's all to be determined. That's why, as I said before, like kind of, although we know some stuff, we still got so much to learn, I think.
Yeah, it's very exciting, and it's very cool that you're involved in this area of work.
Yeah.
So where do people go to find out more information about you, or also any places that you want to direct them to where they can read more about what we've been speaking about?
Yeah, definitely. So, I mean, I use my Twitter quite a lot. So that's at Rayyan Zafar, and I post a lot about the science that we're doing or any talks that I do, like in and around London or elsewhere in the world. And then Drug Science is an amazing website. It's got educational resources, free to use for the public. We have a podcast. We do regular talks for the public, and you can become a community member. So it's a charity, and sign up, donate money, and that helps the research be more readily available for everyone. So Drug Science is a really good educational source. And then if you're interested in actually taking part in any of the research, if you go on the Centre for Psychedelic Research, Imperial College's website, we have 2 tabs: participate in a trial or participate in research, and you'll see a list of the studies we're currently recruiting for. So that's, some of them are for healthy populations, some for individuals with a certain diagnoses, and you can submit a referral to join those studies. So lots of ways you can keep in touch, get involved even, and yeah, carry on like the exploration of the psychedelic science that's happening.
Amazing. Thank you so much.